Okay, so we are going to go over chapter 89, urinary disorders, on page 1618. So basically, this is a super long chapter, like every other back chapter there is. So I'm going to just try to give you the biggest things that I want you to know. Okay, so I'm not going to go over the entire chapter, or not the entire chapter, I'm not going to go over every single little like detail in it. The thing about this book is it gives you so much detail and so much information that sometimes like it's great to know and like I want to know it, but at the same time though, I don't need to know that much detail to do my job effectively. Because if I ever needed to know something super specific about something, I could look it up right there when I'm working, when I have that specific patient. So as long as you understand the general idea of how things work, and then when you have patients that present with like specific abnormalities, like there's some very specific kidney issues and very specific cancers, and I mean specific like heart issues. As long as you understand how things work and the general idea of like like you know the anatomy, you know how it works, you don't need to know like what the specific crazy cardiac thing is. So as long as, but when you have a patient like that, brush up on the information and understand, okay, what am I looking for? Okay, what are the signs and symptoms? What am I expecting to go bad? What am I expecting it to look like? So as long as you understand these things and you can answer the NCLEX questions appropriately, you'll be just fine, I promise. Okay, so on that note, let's learn about the urinary disorders. Okay, so blah, 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 blah. So on the table 89.1 on page 1619, lots of little prefixes. If you know the prefixes, it really actually helps you like understand also more, but you can just like brush up on it real quick when you're at work. So laboratory tests. So the biggest thing when it comes to urine, you're going to do a urinalysis or a UA. So this provides much information about the condition of the bladder and kidneys as well as other body systems. Awesome. So then you're gonna blah blah blah. So let's see here, urinary tract infections in older adults. This is a little special consideration box. Yeah, they present totally untypical of everybody else. They'll usually be confused, they'll be off, and their family will be like, they don't normally act like this, what's going on? And you go, well, hey, how is their voiding? How have they been doing this? Do they have a history of UTIs? Like understanding like what questions to ask is gonna come with time and then just like thinking things through, but I promise it'll come. And then like they end up having a UTI. So the problem with getting a sample from usually the elderly, unfortunately, is you have to do a straight cath, which is not fun for anybody. So straight cath, instead of doing a Foley and leaving it in place, you simply put a tube up there, grab a sample, and you take it right back out. Super important to be very clean and as much clean and sterility as you can. You have to be, because you can introduce a new UTI or just cause further trauma or whatever. So super important to be careful with that. Okay, so let's see here. So then table 89.2, conditions indicated by abnormalities in the urine. This is really cool. Also, if you can just remember, like generalize like, oh, their pH is wrong, so they must have maybe gout, a calculi, or infection. Or they have proteinuria or albuminuria, proteins in their urine. Could they have nephritis? Could there be a kidney stone? Could there be something renal circulatory difficulties? Blah, blah, blah. So understanding like kind of like what to look for and like what to expect helps you like critically think and help take care of your patient better. Anyways though, those are just things you're gonna look for. Okay, so 1620, a key concept. Bacteria in a urinalysis sample will reproduce if the specimen is not refrigerated shortly after being obtained. To prevent false readings, be sure that biologic specimens, urine stool wounds, are processed according to facility protocols. As soon as you get a sample of something, send it off. Send it to the lab as soon as possible, because they know what they're doing up there to like get the information and send it off or get it tested. So send the sample ASAP. So let's see here. So then it talks about urine cultures. Again, any culture you have, get the culture before you start any sort of antibiotic treatment, because you don't want to like mess it up at all. You have nursing considerations, blah, blah, blah. So more renal function tests. The BUN test, B-U-N, blood, urea, nitrogen test determines how efficiently the glomeruli remove the nitrogenous wastes, or urea, that result from protein metabolism. The most common cause of an elevated BUN is kidney disease, although BUN also may be elevated in clients with high dietary protein intake, diabetes, some malignancies, or improper protein metabolism. Okay, so then the next test is what's called a serum creatinine. It's a product of protein metabolism, is related to muscle mass and excreted by the kidneys. So serum creatinine is a much more accurate indicator of renal function than serum BUN. An elevated serum creatinine level usually indicates a serious kidney disorder. So they're looking for proteins and muscle mass, and usually like when you have rhabdomyolysis, remember that thing is going to be like that red bloody urine from somebody that's fallen, lots of muscle is getting out from the kidneys, and you're thinking, oh my gosh, what's going on? So that can also mean a serious kidney disorder. So you're going to do looking for that BUN. Serum creatinine is going to tell you what's going on as well. And then you have just a general creatinine level. So creatinine clearance is one of the most valuable tests to identify early kidney disease, and it is useful in monitoring the renal function of clients with known kidney disease. So they do a general creatinine almost every time when they have somebody like that, just to monitor and to see how things are going. So let's see here. So imaging studies. Oh my gosh, there's so much in this chapter about it. Basically, a lot of the time you're going to do a CAT scan, a CT. So a computed tomography thing. And then you have nice little different things you can look at, whatever. Another thing that you're going to be doing is a endoscopic procedure, the cystoscopy. So a cystoscopy examination allows the healthcare provider to view the inside of the bladder through a tubular instrument, the cytoscope, which has a mirror, an electric lamp, or fiber optic lens on its end. So this picture 89-1 shows a picture of the scope going into a male's urethra and then going into the bladder. And they are like this, like they're looking at it like this. One time, I don't want to say too much of the story because I'm on YouTube, but I had a very interesting urologist who's a urinary specialized in doctor, a doctor specialized in urinary, who was just like super like crazy with this, and like fluid was going everywhere, and I was like, oh my gosh, what's happening? And anyways, it's a good story. I'll have to tell you in person next time. Anyways, though, they go in there and they look in there and they see kind of what's going on, if any sort of thing, because it's super important to be able to pee. If you don't pee, you're not happy. Okay, so let's see here. A lot of the time, this is a very sterile thing. They're going to go in the operating room, but sometimes the operating room isn't open or available, so then they just kind of do it. They improvise right there in the room. So you could be assisting a urologist with cystoscopy in your patient's room while you're having another few patients that you're trying to take care of, and you're like, oh my gosh, let's get this going. Anyways, though, so because the fluid medium is infused in the blood, so a lot of the time they also have like giant bags to help filter out like a Foley, like if there's a bleeding in the bladder, they help filter that out as much as possible. So you have a lot of pressure going in all the time right there in that bag. So you just have to be careful with how much pressure you're doing, because sometimes you could put like, let's just say they already have like bacteria infested urine and you're putting lots of pressure in there, it could just shoot right back up to the kidneys. Because let's just say you have an infection right there at the urethra. It's going to travel right back up the urethra to the bladder, and that bladder is going to be going right back up the uterus to the kidney, and that could cause another infection, and then just so on and so forth. So just watch that travel back into the body. So just be careful with that. Okay, so again, get a urine sample or a urine culture before they do any sort of procedures down there. Anyways, basically when someone walks in the door, pee in this cup for me. We're going to hang on to it just in case we need it. That's what you're going to say. Okay, so nursing considerations. So remind the client to report signs or symptoms of a urinary tract infection or increasing blood in the urine. If there's anything going on down there and they're just like, yeah, by the way, write it down, talk to them about it, and then make sure everyone's aware of it. Okay, so blood in the urine, not a good thing. Biopsy. Basically, again, the kidneys are supravascular, so depending on how they get the biopsy, you got to put pressure, you got to get them the amount of time that they need to rest and keep that kidney from hemorrhaging. So give the client a sedative as ordered if they're getting a biopsy. Place the client in a prone position with a sandbag under the abdomen. So when they're laying down flat on their belly, you're going to put something on their belly to help push that kidney up. Kind of cool. So blah, blah, blah. They have to lie flat for the next 24 hours and really watch their vitals. Make sure they're not bleeding anywhere. Check the site all the time. Make sure it's not like like getting that purpura type look. Blah. So always keep an eye on things because of the vascularity of the kidneys. So then they have the urodynamic tests, a series of tests that determine the actual function of the detrusor muscle. Great. So basically, the thing that you're going to do the most is what's called bladder scan. And you're going to take this nice little like ultrasound type device with a nice probe, put it right there in their bladder, and it's going to tell you how much urine they have in their bladder that they're retaining. And like the book says, anything greater than 150 to 200 mils, you're probably going to, is some sort of disorder and they're retaining it. So, sorry, let me go back. So, if someone's having trouble peeing and they're like, I don't think I'm emptying my bladder. I'm like, okay, let's check to see what's going on. You go pee. I'm going to measure your bladder now. Let's just say they have 500 in there. Okay, great. You go pee, and then when you come back, I'm going to measure it again. They come back, and you measure their bladder volume again, and they have about 175 in there. And you go, you're retaining, something's going on. So, that's what's called residual urine volume, is the amount of volume left in the bladder after they peed, to see how well they're emptying everything out and how everything down there is functioning. So, again, anything over 150 to 200 mils usually indicates that they're not doing a very good job emptying. Because normally, we should be able to empty out our entire bladder and just continue on our day for the next 2 to 5 hours and pee again. Okay, so then it talks about, so those are the things, so that's important to know because you will use that all the time in your practice. So then you have a blah, 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 you're the pressure blah, 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 blah. Okay, so then you have data gathering when it comes to the urinary system. Ask a ton of questions. People will answer. They don't know how to tell you things. They don't know how to explain things. But if you can ask them and be like, hey, how are you peeing? How often do you pee? What's the color of your pee? Do you feel like you're emptying your bladder? And then you have the urologist that's going to ask another like 50 questions to go with it because they are like very specialized. So as long as you kind of know like, what are you drinking? Are you drinking enough? Do you think you're drinking enough? Blah, 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 blah. It really helps narrow things down to kind of like pinpoint like, oh, okay, they're probably, that's what's going on. Okay, so then you have some general nursing considerations. Okay, sorry. So in practice, data gathering and nursing 89.1 on page 1623 has a nice list of questions to ask your patient. Okay, so then I'm going to keep going on. So general nursing considerations. So, I mean, there's a whole list. Again, it kind of just re-emphasizes that little box of data gathering. So just knowing that kind of stuff. Okay, so then it talks about post-operative, key concept. Infection of the urinary tract can result in life-threatening damage to the kidney if not treated promptly. Therefore, preventive early treatment is vital. That's very true. Okay, so post-operative care. It talks about if there's any sort of like surgery in your kidney. Again, it's very vascular. You gotta check for that bleeding and you gotta check for their vital signs. Make sure their blood pressure is staying stable, their heart rate is staying stable, because lack of circulating volume equals shock. Shock, you're gonna have a rapid heart rate and a low blood pressure, and you're gonna go, oh my gosh, what's going on? So, nursing alert. Instruct the client and family members to report chills and fever. They are signs of infection. Other symptoms of complications from a kidney surgery, include sharp abdominal pain, hematuria, blood in the urine, anuria, absence of urine formation, dysuria, painful urination, or urinary retention. All of those things can have a part in what's going on. So additional measures, make sure you're getting them pain medication to go home with. Check for any drainage tubes that are going to be inserted in there with their surgery. Watch their vital signs and tell them to keep an eye on things, especially if they have a fever, if they feel warm at all, check their fever. And then just if they're all of a sudden draining a large amount of fluid, be like, come to the ER right away and call your urologist on the way to the ER. Okay, so let's see here. And then how to manage, let's say if they have a Foley, how to help them manage it at home. Super important to teach your patient that. Really, really emphasize on teaching. Nurses are huge educators. Okay, so key concept. Because many diagnostic and minor urologic surgical procedures are performed on an outpatient basis, they go in, they leave. Aggressive client and family teaching is required. Clients and families must know how to perform pre-operative preparation and untoward signs to look for after the procedure. Carefully document this teaching. Document, document, document. Okay, next we're going to talk about urinary incontinence. Incontinence refers to the involuntary voiding or urine loss. So that's when they kind of leak. It's that leaking that just sucks to have. So you have temporary incontinence. So that's referred to as a reversal. You can reverse that. by means of just like, usually Kegels is the best way to reverse things, but they have like medications they talk about and different things like that. So then you have true or total incontinence. So again, okay, sorry. So incontinence is the weakening of the muscles down there, because your body is made of muscles. And so the detrusor muscle, I'm pretty sure is what it's called, is just weakened. And then an external sphincter, you just can't hold it because that muscle is just weak. So you're just trying to hold it, and that passageway is there. So exercising and emphasizing, just like every time you think about something, just do a little Kegel. Think about it. Anyways, though, true or total, not only for women, men can do it too. So true or total incontinence. So the most common cause of true incontinence in men is surgical removal of the prostate, which happens a lot, which is really important to emphasize when you're talking to your patient about that. So, and then for women, it can be injury to the female's perineal musculature or muscles from trauma or from childbirth. It's a big thing. Okay, then you have stress incontinence, which again is from usually childbearing or from labor and delivery, is having a baby, because that muscle is so stretched and there's so much pressure and it's being weakened and blah, blah, blah. So emphasizing every woman that has a baby, do your Kegels. Put a little sign up on your bathroom and just do them right there. Okay, so, and then let's see here. So men frequently have stress incontinence after surgery to the prostate again. So then you have reflex incontinence. Is caused by bladder instability as a result of upper motor lesions or neuropathies. Urge incontinence is caused by irritation of the bladder wall. So the client usually cannot stop their urinary stream once it starts. So that's like the urge or reflex incontinence. So once it's going, I'm not going to stop it. Overflow incontinence. It happens when the bladder overfills with urine, is not able to release it because either the detrusor muscle no longer contracts. Usually for a central spinal cord injury, you can see that too. Okay, so in addition, clients who have this type of incontinence, the overflow incontinence, are generally more susceptible to urinary tract infections. Because if you have a full bladder and you just have urine sitting in there for like hours, it's just a nice little reservoir for bacteria to start growing and proliferate and just causing infection. Okay, so treatment, Kegel exercises, medication therapy, and then you have also electrical stimulation. It kind of talks about that. So, and then they have, let's see here. So the Crede, and then, okay, so that's treatment. And then how to empty your bladder and all that. What's called the Crede maneuver. So basically you're just going to have your hand, like the heel of your hand right there on your bladder, their bladder. And you're just going to kind of like massage that bladder to help empty it. So when they're sitting in the bathroom, you're just going to kind of like push it down, kind of like that. Sorry for the visual. Anyway, just kind of like help push it. So just practice on yourself when you're sitting there. Just like go like that. You go, oh wow, yeah, there's nice little pressure on there. So that's called the Crede maneuver. You're gonna use that a lot, probably in like the more of the elderly population. It really helps empty their whole bladder. Kegel exercises. It's just like using that muscle down there, like how you hold your pee in is that kind of muscle that you're using to strengthen. Then it goes on to different things. Please take a look at it. So then you have medications. So then you have Detrol or oxybutynin, and also tricyclic antidepressants can help with that whole thing down there. Surgery, blah, blah, blah. So the nursing considerations for all this is for the urge and reflex incontinence, that's like once you're going, include encouraging fluids. So again, they're like, I'm going to pee, I don't want to drink that much. Just like drink. I know it's annoying, but it actually will really help your body regulate. It'll help your bladder like retain and like relearn how to do things. Also, it'll help prevent infection. So this nursing consideration, and also look at the little box and practice box, emptying the bladder completely. I want you to read this box and I want you to know this box. On page 1626, educating the client, 89.1. So let's see here. Also, sometimes when it comes to like not being able to empty the bladder, they have to do self-catheterization. So they have their own little kits at home and they just self-catheterize themselves every, 2 to 5 hours or so. It kind of depends on the patient, and they kind of figure out how their body works. Okay, so urinary tract infections. Acute cystitis means inflammation of the urinary bladder. It is probably more commonly called a urinary tract infection. Cystitis, UTI. Let's see here. So the most causative agent of a UTI is E. coli. Ugh. And that's usually, anyways, okay. So signs and symptoms. The client with cystitis has an urge to urinate frequently, so constant needing to go, burning, sometimes back pain, sometimes just not feeling well. they're like, sometimes when people have chronic UTIs, they're like, I think this is a UTI. You test your urine, it's positive, boom, here's your antibiotics, go home. So, and then let's see here. So then the treatment, antibiotics, or sulfonamides are ordered as a result of sensitivity testing. They can also be given different things that help with that bladder spasming and like the irritation. Phenazopyridine, I don't know how to say these things. Anyways, it can cause your urine to look orange and reddish. So when they're like, dude, my urine is super orange, you're like, totally normal, don't worry. Okay, so nursing considerations. This is an important thing to know. So many people have UTIs, know this. Top of page is 1627, nursing considerations. Teach preventative measures, such as the importance of drinking lots of fluids, avoiding tight-fitting clothes, cotton underwear is the best, avoiding irritants such as soaps, like when you're down there, clean it, but don't get like super aggressive. Also explain the diet's high in sugar. Sugar is a huge bacteria eating thing, like bacteria loves sugar, don't eat sugar. And then just when women, wiping from front to back, don't go back to front because you could reintroduce bacteria from your little bumhole to your urethra. So front to back, clean it that way. Also, they talk about how cranberry juice can help. Yes, it can. However, sugar-free cranberry juice is what you need to drink. Sugar-free. Awesome, that'll really help. Okay, so during antibiotic treatment, fluid intake of 3 to 4 liters daily is recommended, unless contraindicated. Additional fluid helps dilute the urine, thus lessening burning on urination. So helping keep that hydration and help just flushing things out of your body. Super important. Also with antibiotics, you need to talk about probiotics because it'll just wipe out your gut. Okay, so people with chronic UTIs will often be placed on long-term antibiotic therapy lasting 3 to 6 months. So also, let's see here. So this is an important thing as well for the antibiotics. So teach women to wipe from front to back to prevent sweeping bacteria into the urethra. Monitor the client on long-term antibiotics for candida or yeast infections, also known as mononlysis. Yep, talk to them about it. It can happen. It sucks. So they have to get an antifungal for that. So when it comes to also another thing for UTI, special consideration, is little kids. They're also susceptible to it, and little girls are very susceptible to it because they just they're learning how to wipe it down. And I didn't know this, but apparently bathtubs can be a huge breeding ground for little girls to get UTIs or for children to get UTIs. So once they're in the bathtub, just get a clean cup of water and just wash it off real quick and then get them out. So it's just something to keep in mind. Okay, acute pyelonephritis. It's the inflammation of the renal pelvis and medulla is the most common form of kidney disease. E. coli is the most common contamination when it comes to acute pyelonephritis. So, urethra, bladder, ureters, and then you got your nice pyelonephritis up there in the kidney. So that's just traveling up. Just watch how it travels. That's how it does. So signs and symptoms of acute pyelonephritis are rapid onset of fever and chills with flank pain, pyuria, nausea, vomiting, and headache. The client with this condition is very ill. Okay, so nursing alert, because many diagnostic and minor urologic surgical procedures are performed on an outpatient basis, aggressive client and family teaching is required. So make sure you educate as much as possible and be aggressive about it. So the treatment for this is usually an antimicrobial therapy for at least 10 to 14 days. For example, penicillin is an antimicrobial. So nursing considerations, bed rest, plenty of fluids. Again, talk about all the little things. And then there's a little educating the client, signs of infection, dysuria, frequency, nocturia, all that kind of stuff. Know that stuff. Then you'll be like, kidney, something's related to your kidney. So chronic pyelonephritis is the kidney becomes permanently damaged, and because kidney tissue is not replaced, renal function is lost. So treat the infections right away. Then you have the inflammatory disorders, interstitial cystitis. It's the lining of the bladder becomes leaky and allows irritants from the urine to contact the muscular wall of the bladder, causing irritability. So you have a nice little bladder, and then it's just kind of sloshing off, and then all that urine is just going to irritate that skin that's just exposed now. That's not normally supposed to be. So that can cause interstitial cystitis. Signs and symptoms. Unlike cystitis, a UTI, voiding is usually not painful. Instead, it provides relief from the bladder, pain, and spasms because getting that urine out is going to decrease that irritation. So they're just like the opposite. Oh, I feel so much better after I peed. What's going on with you? So treatment. Treatment of this chronic disease is difficult and consists of symptom management. There is no cure. So lots of hydration, keep things as like dilute as possible, and just constantly voiding is just going to help them out. So that really sucks. So nursing consideration. Let's see here. Instrumentation frequently causes flare-ups of symptoms, so it's important to do as little manipulation of the pelvic area as possible. Basically, leave it alone. Try not to do anything. And sometimes intercourse can be painful too, so a lot of this can be a lot of like mental health as well. So just providing them any sort of therapy or anything that they need is going to really help them feel better too. So, glomerulonephritis. It may be a result of an acute bacterial, viral, or parasitic infection. So let's see here. So it's a group of diseases in which the kidneys are damaged and partly destroyed by inflammation of the glomeruli. So anything that goes on the kidneys is going to affect the entire thing. So there's a handout, actually, I want you to look at now. Nephrotic versus nephritic. Know this, read this. Super interesting, super helpful. Know this. Because nephritic syndrome, nephrosis, may result from glomerulonephritis and is characterized by marked protein in the urine and edema. Look at that handout. I'm not going to go over it because you can read it and you can try to remember it. Okay, so acute glomerulonephritis. Basically, so a disorder of the glomeruli that starts with inflammation. Bacterial endocarditis, often causing infection in the heart valves, can trigger glomerulonephritis. Viral infections such as HIV, Hep B, and Hep C are also associated with glomerulonephritis. Many disorders such as lupus or diabetes are the main causes of secondary kidney diseases. So again, any sort of comorbidity has huge roles and other things that's going on in the body. So just knowing what's going on and how to help them, blah, 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 is going to help understanding why that glomerulonephritis even started. So signs and symptoms. They're going to be pale, they're going to be puffy face and swollen tissues. They could have hypertension, headaches, edema, irritability, loss of appetite, general malaise, and body aches. And then also, they're going to have a lot of protein in the urine, which is going to cause a foamy urine. So proteinuria tends to result in foamy urine. So just a lot of foam, you're like, your kidneys aren't really working. So nephritic syndrome is a condition characterized by too much protein in the urine and too little protein in the blood. High cholesterol levels and severe edema of the eyelids, feet, and abdomen. So once you kind of remember what signs and symptoms kind of are, you kind of just look at people and you go, your kidneys aren't working that great. So it's kind of, once you pick those things up, it's kind of cool to like Sherlock Holmes. Anyways though, so diagnosis is made initially by the urinalysis. The UA will show the urine to be more dilute, meaning that the urine consists of more water than normal. Dilute urine is due to the lack of filtration in the glomeruli. Dilute urine is due to the lack of filtration in the glomeruli. So, know that. Treatment, so the treatment goal is to restore the kidney to its best possible function. So you're going to have maybe antibiotics, steroids, diuretics will help, antihypertensive agents, things like that. Just whatever you can to help with that. Okay, and then just lots of rest. They need to just relax and rest. Okay, so they are not considered well, however, until their urine has been continuously free of albumin and red blood cells for several months. The treatment for long-term or end-stage renal failure is dialysis or kidney transplant. Okay, so again, talk to them about drinking, talk about their INOs, talk to them about emptying their bladder, all the things that you can do. So when there's chronic glomerulonephritis, it may develop immediately after an acute episode. So chronic glomerulonephritis is much more serious and acute because it permanently damaged the kidney by destroying nephrons and thereby disrupting function. So nursing alert. Chronic glomerulonephritis can have serious complications including pulmonary edema, increased blood pressure, anemia, cerebral hemorrhage, heart failure, and ultimately renal failure. Because think about it. Kidneys play such a huge role in the RAA system by blood pressure regulation and by all about that fluid. Any excess fluid is just going to start building up in your body. So kidneys are a huge game changer when it comes to the functioning of your body. Okay, so signs and symptoms. You're going to see anasarca, generalized all body edema. The disease flares up at intervals, but the client usually feels well between attacks. So you're going to feel okay, then an attack. So also a nosebleed, epistaxis, and gastrointestinal bleeding are common in terminally ill clients when it comes to the chronic glomerulonephritis. Treatment includes treating the edema with diuretics, monitoring blood pressure with antihypertensive medications, and dietary restrictions of salt and water. Protein in the diet is typically minimized, which will reduce the amount of protein breakdown products such as ammonia. Nursing considerations. When signs of a flare-up of chronic glomerulonephritis appear, place the client on bed rest to reduce metabolic waste and preserve strength. In the absence of dialysis or a kidney transplant, however, prognosis is poor. So if they don't really have a lot of options, they're not going to do so great. The person with chronic glomerulonephritis is very ill and needs close observation and skilled nursing care to monitor for and treat related renal failure. So then you can have end-stage renal disease, ESRD, may develop in some cases of the chronic glomerulonephritis. Okay, so that was a long handful. Anyways, obstructive disorders, basically what's blocking the urine from going out the body. So, complete obstruction anywhere in the urinary tract system is a medical emergency and must be treated quickly before renal damage occurs. Hydronephrosis develops when urinary obstructions block the outflow of the kidneys. Hydronephrosis may be gradual, partial, or intermittent. Signs and symptoms. A bladder infection also is likely because, signs and symptoms. You're not peeing, you're going to have flank pain, your kidneys are going to hurt. It could be depending on where the stone is at. That could be like, oh my gosh, like the front of my lower abdomen really hurts, where my ureters would be, or my back really hurts, where my kidneys could be. That's where the stone could be. Or oh my gosh, it hurts like heck to pee right now. That could be where the stone is. So that's usually like a big indication. They're super uncomfortable. They're just not feeling great. They're not happy. And it's like, ooh, it's really painful, and you're trying to get something like a little stone out of a very tiny little hose. Okay, so UTIs can also, can happen too. So treatment. Lots of things can happen. A lot of the time, depending on the size of the stone, they just pee it out. So when that happens, you have to get like a little filter, have them pee through the filter every single time they're peeing to see if they can catch anything, because it can be like as tiny as like sand, or it can be like little big stones depending on how big they are. So they're usually going to do a CAT scan to see how big the stone is and measure it, or to see where the stone is at. Let's see here. And then, so lots of hydration is important. So little things here, sorry. So when it comes to ureterolithosis, so this is like a stone basically in any part of the body. So calculi are seen in individuals who have had gastric bypass surgery, inflammatory bowel disease, and chronic diarrhea due to changes to the body's ability to absorb calcium and water. They don't really know how stones are formed, but they know that infection, dehydration, low calcium intake, and urinary stasis contribute to the formation of stones. So also, cystinuria is an uncommon genetic disorder that causes stones to form in the kidneys, ureter, and bladder due to excess precipitation of the amino acid cysteine. So sometimes it can just happen a lot to some people. So the diagnosis, again, is a CAT scan. You're going to have them filter their urine out. So this is an important test question. Often, the pain that they're experiencing from kidney stone is called colic, an excruciating pain that comes in waves as the ureter tries to force the obstructing stone onward. Nursing alert. Investigate hematuria, blood in the urine, because it is signs of infections, stones, and cancers. The usual investigation starts with a clean cat specimen or by a single catheterization in a woman for urinalysis and culture. The treatment for a stone. So it begins with adequate hydration. Drink a lot of water. Help get that stone out. Let's see here. So lots of pain medication as well can help. And then most of the time the stone passes on its own. Sorry. So sometimes they have to do a surgical removal. So this whole page, 1632, talks about all the different ways they can get it out. One of the coolest ways I thought was really cool, where is it? Was the ESWL, the kidney or ureter stones, the extracorporeal, outside of the body, shockwave lithotripsy. Super cool. Basically, they just send high impulse waves to help break down that stone so it's easier to get out of the body. Cool. So when it comes to surgical removal, just make sure you know that, again, everything's a little vascular. The urine is going to be a little blood tinged, so it's totally normal. So again, when you're straining the urine, save every little thing that like could be there and just stick it in a cup, send it to the lab, test it, see what's going on. Again, it could be small as grains or sand or as large as pebbles. Could you imagine trying to pee something out like that big? Oh, that'd be so painful. So, and make sure when you're doing any sort of documentation, like or patient teaching, document all of it. Be like, educated patient on what to look for when it comes to straining urine, things like that. Like you'll understand the jargon that you're going to be using. So let's see here. Again, when it comes to that ESWL, the extracorporeal shockwave lithotripsy. So this, you're going to watch that urine for the next 24 to 48 hours. And it's going to be blood tinged. Let's see here. So just know that once they have one kidney stone, they're at a high risk of forming more. So just let them know like, hey, this could happen again. Now you know what it feels like, recognize the symptoms, and just come in. We'll do everything all over again, or just know what to look for. Okay, so page 1634 has a great just case study just to kind of look for and like what to think about. Read it. It's really good. It's good. Read it, understand it, and just kind of like help get your mindset to critically thinking about things. So next we have tumors. So page 1635 is what I'm on now. Benign renal cysts. So cysts of the kidney may be single or multiple. So polycystic, which is multiple cysts, kidney disease consists of multiple clusters of benign tumors on the kidneys. It is genetically inherited. It is a genetically inherited problem. So that really sucks. So just know that if it's a single cyst, monocystic, or a single cyst is usually benign and asymptomatic. So once there's like only one, you're probably good. But if there's more, genetically. Okay, so then there's cancer of the kidney. Nephroma is cancer of the kidney. Cancer of the kidney has two principal origination sites, the renal tubule and the renal pelvis. So the location and cellular type of cancer are important because prognosis and treatments differ. Kidney tumors are almost always malignant. So they occur more frequently in men. Age differences occur. They are rare in people under 30 and increase in incidence in people over 65. Some nephromas have a hereditary risk factor. Renal cancer is aggressive, often invading the aorta or vena cava, just because it's so connected to the abdominal aorta. So clients often have distant metastasis and local invasion of nearby organs. And then just know this for a test question. Kidney tumors in children are generally Wilms tumors. Page 1635, under cancer of the kidneys. So signs and symptoms. Cancer of the kidney is usually advanced before signs appear. They're not even going to know. And a lot of the time when it comes to cancer, you're going to have a fever, loss of weight, general weakness and malaise, sometimes a pallor in color, sometimes flank pain, and then you're going to have them come in and do some tests, and they're going to tell them the bad news. Treatment, it depends on what kind of cancer. It can be curative, or it could just be something they live with until they don't. So, key concept, neoplasms may present with problems to renal function by obstructing urinary flow. Chemotherapy may damage renal function as well. So when it comes to tumors, the bladder is the most common site of urinary system cancer. Let's see here, so tumors may be embedded in the bladder wall or may appear as small warts on the inside surface. Most bladder tumors are malignant. So, signs and symptoms. Usually painless. Bladder cancer is diagnosed with a combination of a CT scan, X-ray, blah, 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 blah. Treatment. You can use chemotherapy, or you can do what's called a transurethral resection of a bladder tumor. Basically, you're just going to like help cut it out, cutting off some things out. And then when that happens, let's just say you take out the full bladder. On page 1637, there's a different pictures to show you how they save the ureters if they remove the bladder when they're in the process of letting things heal, and then just trying to like make a new bladder, just trying to figure out what to do with that. Okay, so let's see here. So cystostomy is an incision made into the bladder, can remove larger or more extensive tumors. If the tumor is large and invasive, the entire bladder may be removed. Cystectomy, radiation and chemotherapy are usually combined with tumor removal. So look at that. And then you have what's called urinary diversions. So diversions are done to divert urine flow from a diseased or defective ureters, bladder or urethra. Depending on what's going on, they're going to just help make it go somewhere else. So most commonly, some types of uteroenteric anastomosis, sewing together, is done. That is, the ureters are anastomosed or joined with an intestinal segment. So again, look at page 1637. It'd be way easier just to look and understand it versus me trying to explain it. Okay. So nursing considerations when this happens, a lot of the time, it's very visual. Like it's a big deal to have anything like different in your appearance happen. So really be patient, really listening to your patient, and just being there for them is the most important thing. Like listening to their concerns. Also, let's see here. So bladder removal for men is often associated with permanent sexual dysfunction. So that could be a huge thing. It is a huge thing. That is a huge thing in someone's life. So again, listening to your patient and just trying to help them live with the new norm is what you can do. So, key concept. Urinary diversions are provided to promote the elimination of urine from the body. Unobstructed, intact stomas or other urinary structures are crucial, along with good skin care, emotional support, and client teaching. So, when it comes to urinary tract trauma, again, I'm on page 1638. Let's see here. So, again, any sort of laceration on that kidney, super vascular, can lead to shock or any sort of hemorrhaging. So, a very common injury sustained in a motor vehicle and other accidents is bladder rupture, which results in shock, sepsis, or hemorrhage. So, super important. Okay, so then you have, so again, vascularity, keep that in mind whenever you have something going on with the kidneys. Renal failure. Renal failure or kidney failure exists when the kidneys no longer meet everyday demands and there's a significant decrease in the glomerular filtration rate. So that's going to be a urologist, specialized doctor, and all that kind of clinic is going to help measure all that. So the phases of renal failure may be characterized by oliguria, lack of urine, or diuresis, increased urine, or they may fluctuate depending on the cause. In renal failure, the kidneys become unable to remove waste products from the blood and body cells and excrete them in the urine. This toxic condition is associated with renal insufficiency and retention of nitrogenous substances in the blood. Abnormal levels of potassium, calcium, and phosphate are found in the blood. Anybody with like renal failure, they're going to have really crazy labs. So a lot of times they're not going to be peeing. So you have somebody on like dialysis, and you're going to be like, oh my gosh, oh, you have dialysis. So levels are going to be super off because things aren't working anymore. So also common drugs and substances that can become nephrotoxic. Box 89.2, look at this. Penicillin, heavy metals, NSAIDs, things that you just like don't even think about. You're like, oh my gosh, I take ibuprofen and Tylenol all the time. So super important to know that. So the nephrotoxicity of a drug must be determined before the agent is given to a client. Whenever administering medications, watch for signs of kidney dysfunction and report them to the healthcare provider at once. So, acute kidney injury, also referred to as acute renal failure, is due to injury, hemorrhage, or severe reactions to some medications. So, without the ability to make urine, the result is a decline in the glomerular filtration rate. So again, kidney injuries can happen from any little thing, trauma, whatever. Signs and symptoms is usually oliguria, no urine. So that's a common early phase of renal failure. Okay, so then there's like different lab values. You can check out all that, blah, blah, blah. Key concept, recognize signs of acute kidney injury and treat them promptly to prevent progression to permanent renal failure. Symptoms vary, but close monitoring of intake and output as well as creatinine, BUN, GFR levels, and electrolytes can provide valuable data to try to arrest the disorder. So treatment, so you're going to do all your lab studies. It's going to maintain your homeostasis of fluid and electrolytes. IV fluid is super important. They're going to monitor the electrolyte levels, the glucose. Really, hyperkalemia is a big thing when it comes to kidney injury. So that's an increase in potassium, which can lead to arrhythmias. Our heart is really impacted by potassium. Muscle weakness. You're also going to take a look at calcium, glucose, and sodium. And a lot of the time you're going to give them K-Exolate to help reduce their potassium level. And K-Exolate is a great way to make people poop. So if you give it, get ready for them to have to go to the bathroom. And unfortunately, a lot of the time with kidney failure, you have just like a decrease in body functioning, and it can be really difficult for people to mobilize. So it can be quite the challenge when you're taking care of them in the hospital. So just a heads up. So temporary dialysis may also be used with acute kidney injury. And let's see, dialysis, we'll talk about that in a second. Okay, so nursing considerations will involve client teaching regarding the importance of self-regulation of one's diet. A dietitian should be involved. Avoid foods with extra sodium chloride, and then suggest low potassium foods, and then avoid high potassium foods. And then phosphorus, a mineral, also needs to be limited. So take a look at that nursing consideration. End-stage renal disease, ESRD, occurs when the kidney failure is permanent. Dialysis or a kidney transplant is life-saving. Most cases of ESRD are caused by diabetes, hypertension, inherited disorders, side effects of polypharmacia, or specific medications, and severe kidney trauma. So any of those things can contribute to that. So nursing considerations with that are designed to treat the primary cause of ESRD and treat symptoms as they occur. So just take it on a daily basis. So, so there's a whole list of nursing considerations when it comes to ESRD. Take a look at it. And then the symptoms of it on page 1640, take a look at that too. So a key concept as well. So a healthy kidney produces the hormone erythropoietin that is necessary for the production of red blood cells. A person with kidney disease may be short of breath, anemic, or chronically fatigued because he or she does not have enough hemoglobin molecules to carry oxygen. Be aware of using a pulse ox to establish a rationale for dyspnea because a pulse ox reflects the capabilities of existing hemoglobin levels, which can be misrepresented as normal oxygenation. So again, that pulse ox is great for a normal, healthy person, but sometimes it can be really off for somebody that's not healthy or that great in condition. Okay, so kidney damage is usually going to lead you to, or end-stage renal disease, dialysis. What is dialysis? It's the process that assumes the work of a damaged, non-functioning kidney. There's two types. There's peritoneal and hemodialysis. The purpose of dialysis are to remove waste products of protein metabolism from the blood, remove poisons or toxins from the blood, remove excess water, establish or maintain proper levels of electrolytes, maintain acid-base balance, and instill medications, electrolytes, or other substances. So you have peritoneal dialysis. Take a look at it, read it, try to understand it. Basically, you just go home and you can do it at home. But hemodialysis is where you're going to really be seeing those patients. So they're going to have a fistula a lot of the time, or a graft. And remember that picture in class we talked about? Basically the two joining of that. You're going to stick a needle right in there, 2 needles, one to take the blood out and one to take the blood right back in after it's already filtered. Types of shunts, take a look at that. Sorry, the baby's crying. Possible complications of a hemodialysis, all on page 1642. Hey Nick, I'll take her.
She's hungry, baby.
Okay. I can take her.
Going right now?
Yeah. Hi, honey. I'm so sorry. Oh, I love you.
Are you still doing your teaching?
Yeah, I'm like almost done. Sorry, guys. Look at that pretty girl. Can we just talk for a minute, then I'll feed you? Hi, hi. Oh, oh, oh. Okay, so when it comes to the key concept, when it comes to their graft or their fistula, they're going to have what's called a thrill, which you're going to put on their arm, you're going to feel it, and it's going to be like a vibration. And then, and then you can take a stethoscope, and you can listen to what's called a bruit. There's like a whoosh, 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 whoosh sound. So check for those two things to check for the patency of both of those. Super important. Oh, I love you. Okay, so always take a look and tell your patient to be checking that too. Sometimes they can just put their ear to it and you can just hear it, and then they can just feel it themselves to make sure that it's actually working. So, key nursing alert on page 1642. Cannula separation is life-threatening. So remember that story I told you about the guy that pulled it out? Super vascular. It can make you bleed to death if there's any damage. So be really, really careful. You look so beautiful. So complications associated with hemodialysis. So there's a whole list, but air emboli are really important. Hypotension, and then you can have sometimes just total like hemorrhaging can happen. So again, hemodialysis, you're doing it in a clinic. They're going 3 times a week. Their life is connected to that machine. Their quality of life can sometimes be really poor. So again, it's really important to listen to your patients and help them out as much as possible. Hi, sweetie. So especially nursing considerations. So take a look at all that on page 1642. And then just know with the kidney transplant, I mean, they're going to talk about it. The donor must have a really well-functioning kidney to give one, to make sure they can live with only 1 kidney, because then their life is also impacted from that. And then let's see here. So then also your body can be at risk for rejecting a new organ. So, and that's all very specialized. So just know that it can happen. And then so also I want you to take a look on page 1643, the nursing care guidelines, 89.1, caring for the client receiving dialysis. They're going to be super tired the rest of the day, and it can be a 3 to 8 hour process. So just understanding how that works and how that functions is really important. Again, do not touch that fistula or that graft unless you're specifically trained to. I don't even touch it. Nobody touches that unless they know exactly what they're doing. Don't mess with it. And that's pretty much the chapter. Again, if you guys have any questions, please let me know. And sorry about the baby and the interruption. Thank you so much. And just take a look at everything. Read the chapter. I know it's long, but just like sit and watch a movie while you're reading it and just get it done. That's all that matters. Thanks, you guys. Hang in there, and you're doing great. Bye.